Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Linda Knodel and Karlene Kerfoot. They are both nurse executives. Today's Kevin MD article is titled Unleashing the Power of Optimized Operations, Data Connectivity, and Technology for Unparalleled Patient Care. Linda and Karlene, welcome to the show.
Thank you, Kevin.
So I'm going to ask each of you just to briefly share your story and journey, and then we'll talk about your article. Linda, why don't you go first?
Absolutely. Thank you again for the opportunity. With over 49 years of healthcare experience, I have served in the acute care realm. I've served in ambulatory as well as in the post-acute areas. Most recently, the last 20 some years, I've been a system chief nurse executive at very large systems across the United States. And what that's afforded me is the fact that we've been able to sit as nurse executives, sit at tables where executives and nurses have not sat before. We've been able to influence not only at the local, regional, and national level, but at the political level as well.
So Linda, just to follow up on that, just give an example of how you as a nurse has influenced decision-making at any of the institutions that you work with.
One great example is that I ran a dialysis unit and patients were traveling 200 and 300 miles 3 times a week for their dialysis treatment. And I went to the CEO and I said, this just isn't right. We need to develop satellite dialysis centers. And that CEO was not only a mentor of mine, but he understood how important patient care was and the voice of the nurse. He said, go ahead and do it. And today, those dialysis units, as you well know, with the chronic kidney failure, the incidence has increased, but those are there now in the communities. The patients can still live and work in their communities, and the travel has been eliminated.
All right, Karlene, just briefly share your story and journey to where you are today.
Well, I came to nursing kind of a circuitous route. There's different kinds of leadership career modes, and I am that circular one, that spiral one. I didn't go this way, I didn't go this way, I went that way in a spiral sort of way. I came to nursing as a second career. The first career that I really wanted was to be an ambassador and to join the American Foreign Service, and I was fascinated with Afghanistan. So my first major was political science, and then at the end of the equivalent of 3 years, I wrote for applications, and they said, well, we don't take women in the American Foreign Service. We have some secretarial positions, but you can't travel with those. And I thought, oh, what is this? And of course, I grew up on a farm, and I could do anything on a farm. It never dawned on me that there were things that men did and women did. So I said, okay, well, I want to travel, so I'll go into nursing. So then I spent the next 3 years getting prepared to become a nurse, which was a great decision. It was a great decision. And I don't regret any of the time I spent taking all those extra courses that I wouldn't have if I had not been a nurse. So from there, I moved into clinical positions because I really wanted to credential myself as a clinician. But then I kept getting tapped on the shoulder to say, don't you want this nurse manager job? Don't you want this director job? Don't you want this? Don't you want that? So I moved into a leadership position sort of accidentally by not planning a career, but oh my gosh, it's been wonderful, wonderful, wonderful. So like Linda, I was the chief nursing officer, patient care officer. We had lots of different titles for large integrated systems. And the good news about working in an integrated system is it's a challenge to bring diverse people together. But boy, it's so much fun when you do it so you can get the great patient outcomes. And then I took a turn about 10 years ago and decided to go into the vendor community and decided to go into technology. Technology has always been a love of mine, and I developed different things like scheduling systems and so on like that. And then I had the opportunity to work for API as the chief nursing officer for API. And then the past 10 years, that's what I've been doing. And now I'm the chief nursing officer for symplr for the last 3 years, which is a collection of several different companies that really works together to make sure that operations can be seamless for people who are out there on the front line. So it's been been a very interesting life, interesting career, and certainly not the one that most people can go through. It's been different, which is great.
Now, Karlene, for those clinical nurses who may be listening to this podcast and this episode, and they want to make change on a more macro level and perhaps move into a leadership role, what kind of advice do you have for those clinical nurses who may be listening to you right now?
Well, I think the first thing in terms of leadership is get your experience. You can learn a lot in school, but in school, if you take that and then apply it to your experience, your job, then you really, really can do things. Also, I think you need to take a job, not necessarily for what it's going to do for your career, but for the people who you're going to work with. Because I have learned so much from working with hot dog people that I would not have had the opportunity if I had said, well, I got to be here and then I got to be at a bigger hospital and a bigger. I think if you can really work to say, who do I need to work with next to learn what I don't know as well as I need to, and be able to make decisions that way, then you become kind of a Renaissance person who knows a lot about different pieces of leadership versus a single function. And that prepares you for the future, because the future is going to be very diverse and very different than what we have now. It's not going to be that linear single function thing. So the more experiences you have, the easier it's going to be for you to be able to move in that.
All right, let's talk about the Kevin MD article. Today is titled Unleashing the Power of Optimized Operations, Data Connectivity and Technology for Unparalleled Patient Care. Linda, how did this article come together?
Well, I have the privilege to serve on the executive council for symplr. And I've been able to learn over the last 2 years being on this executive council, the number of systems that symplr has and is able to provide consumers and the healthcare community. Right now, and if you were to walk into a hospital, there would be 50 to 75 different systems that are operating all the time within the hospital. And what symplr has done, and I believe that they have a very, very strong niche, is that they've got the ability to connect these systems, where with the best of breed model, those systems don't always connect. And what I've been able to really talk about is, and I'll call it CNO math, because an example was a pediatric department. We had 40, 45 nurses on the pediatric department. We were always short-staffed. We were paying extra for overtime. We were calling in people on their days off. We were using travelers. And one day I sat down and I said, there's got to be a way to figure this out. What is going on? Because our HR system didn't speak to the staffing and scheduling system, which didn't speak to the clinical system to describe what are the patient care needs. And at the end of the day, what we found out is 30 of those nurses had been on that unit for more than 32 years. They were eligible for 1 to 2 weeks more vacation. They were also, we saw an increased rate of surgical operations occurring. So that would be an additional 6+ weeks off. And at the end of the day, we ended up with the math being able to demonstrate we needed 7 more FTEs to be able to operate during these peaks, valleys, and really, because you don't use the midnight census to drive your staffing. You use probably between 4 and 8 is your busiest time. So it's really having access to systems. And that's what I saw that symplr has. And I was just so passionate about it. I said, we've got to talk about it more, and the impact that interoperability has on the lives of those that we care for. It is not going to get any simpler going forward. It is going to become more and more complex. And unless we've got the systems that work with us and for us, we won't be able to survive.
So, Linda, to follow up on that, what you described, I'm sure is replicated in hospitals across the country, each hospital having dozens and dozens of different systems that don't talk to one another. How did it get this way? Why is it that the technology infrastructure in a lot of hospitals is just so fragmented? How do we get to this point?
Well, I think because healthcare systems were developed around the finance model. So when we looked at what kind of systems existed, they were finance-based systems. And then as clinical systems began to evolve, and I'm going to call on Karlene, she's been in that space longer than I have. But at the same time, as the clinical systems have evolved, the best of breed was the model of choice. So if you had a radiology system, that's the system you wanted, but it did not talk to the laboratory system or the finance system or the human resource system. So I think the modeling of technology, adaptation, and development is a relatively, 20, 25-year science for us in healthcare. So I would say that evolution is really the driver.
So, Karlene, when it comes to technological innovations in the healthcare space, I'm certainly no stranger to that. Certainly from the EMR side, there's a lot of tension between those two worlds. How can you implement successful IT solutions in the healthcare setting? So many companies, so many people have tried and failed. What differentiates a successful IT implication from something that's less successful?
I think if we take our clues from what we've done with the electronic health record, there's a lot of opportunities there, because if you can remember, and I can remember, when we had disparate systems there, that you had an ER system and you had an OR system and a med-surg system, they didn't talk to each other. So the nurse, to move a patient, had to go into 3 or 4 different systems to be able to do that. And then we put them on one platform and we got them all talking to each other. We haven't done that yet with operations. So if a nurse manager wants to staff and schedule, they have the workforce and the solution. But if they don't look at outcomes, they have to go into the quality. They have to go into a bunch of different ones on their own because it's not integrated like what we've done with the clinical systems. So we have models out there. We just have to do it. And I think, Linda is absolutely brilliant in terms of what she's saying, because she talks about the need for collaborative structure where the nurse leaders can sit down with the supply chain people and the chief medical officer and the chief technology officer and identify how we can make all this stuff talk to each other so the person at the front line doesn't have to do it. If you look at a nurse manager, they got to go through 6 or 8 disparate systems to be able to staff and schedule. It shouldn't be that way. They should be able to go to one system that talks to all these different things and get the work done. But as Linda says, we have to have those collaborative structures to build that connectivity that we have to have for the future. We're on the brink of that, and we're about there. But boy, we got to go faster, because we're losing too many practitioners. They aren't sticking because the technology burden is just doing them in.
So, Karlene, what exactly are the pain points and the friction points that's preventing this interoperability from the operation side?
Well, I think one point is, as Linda notes, is you got to get people to sit down and talk to each other and walk in other people's shoes. We just did an interesting study, the Compass survey, and we asked IT people what their perception of different things were, and we asked the clinical people what their perception of different things were. IT people thought that the clinical people really liked the systems a lot. The clinical people said, no, we got problems here. But that was new information, because they hadn't sat down together, as Linda talks about, to be able to compare notes and to be able to come up with a common view, a common sense view of where we need to go. So one of the problems is, we're organized in silos in organizations, and it's just got to go. Just got to go. We have to follow Linda's lead and say we have to build those collaborative structures to get people talking together.
So, Linda, you've been involved in many healthcare institutions. Are you saying that currently these collaborative meetings where one department talks to another, that's not commonplace, and that's preventing us from seeing what you would like to see in terms of the speed of implementation?
I would say you're absolutely spot on. Not only have we developed and grown up in silos, but we've also not done a good job of what I would like to refer to as shared leadership. What are our shared priorities? Do we sit down with the radiology department, with the laboratory department, with the C-suite, and assure that there is connectivity between the strategic priorities? What are our goals, and how do we measure them collectively as opposed to independent departments?
Linda, in the article, you mentioned the influence of artificial intelligence, which certainly has been in the news for the greater part of a year. Tell us how that influences trends going forward.
Well, I oftentimes speak in parables or in stories. And the story that comes to my mind when you ask that kind of a question is the fact that if or when a nurse performs a procedure and documents that procedure in the medical record, or a medication is administered and it's in the medical record, the ability to pull that data to demonstrate at the individual level, the level of competence, the level of assurance that we are compliant with our systems, charging the right thing for the right IV insertion that was done. And it also demonstrates a level of acuity that the patients have. So artificial intelligence, when used for the purpose of assuring we're doing the right thing and assuring that we've got big data that helps drive decisions in a collective manner, that to me is our future. And with these interoperability capabilities, that's where we'll be able to even further influence artificial intelligence.
We're talking to Linda Knodel and Karlene Kerfoot. They are nurse executives. Today's Kevin MD article is titled Unleashing the Power of Optimized Operations, Data Connectivity, and Technology for Unparalleled Patient Care. Now, I'm going to ask each of you just some of your take-home messages to the Kevin MD audience, and maybe you could just include what we have to look forward to from this data operations side. So, Karlene, why don't you go first?
I think we have a huge opportunity to look at data operations and connectivity and taking work out of the system to be able to, quote unquote, cure many of the problems we have. If you look at why people are leaving, why nurses are leaving, physicians are leaving, oftentimes is number 2 and number 3 reason is the technology burden. And we create that kind of technology burden because we don't have systems, as Linda talks about, that connect with each other. If you look at it in our survey, it's apparent that we can give a lot of time back to physicians and back to nurses and back to clinicians if we take a lot of that chaos out of the system. In fact, the estimates are as much as 20% for a clinical nurse if they didn't have to deal with all the chaos, sometimes even more than that for a nurse manager. So the point is we have to get busy because, we look at hiring more people and doing this and new models of care, but the root cause is that look at what people have to do and take away all that garbage and simplify what their work is. And if you simplify it, then they enjoy their work and they want to stick and they want to stay. But if you don't do that and if you just keep piling on more and more technology that doesn't talk to each other and doesn't help them, then they say, out of here, I'm not going to do it. So we have a huge opportunity right now to think differently and to think about technology as an enabler. And as Linda says, they should be our co-pilot. Technology should be our co-pilot, not the director, not the captain, not what drives everything, but it should be the co-pilot to be able to work with us and be able to make things different. So what that means is clinicians really have to understand some of the technology so they can make recommendations to vendors and also make strong recommendations to the organization, how we can get back 20% of people's time, 30%. And then, our staffing issues are somewhat solved. People will want to stick more then.
Linda, why don't you end off with your take-home messages to the Kevin MD audience?
Absolutely. First of all, we've got a very large system here that we're talking about. It's very large, but we also don't have the time to be able to allow that boat to turn very slowly. We need to be far more nimble. And I would say, number 1, as a leader, be sure you're balanced. Balance is best possible. Secondly, Keep your priorities at the forefront. Stay focused. Is it technology? Is it development? Keep your priorities at the forefront. And then I always say, love life. Because if you need to love life as well as what you do in life, because we get this one chance, and it's like, let's do the best we can with what we've got, communicate and collaborate with your professional colleagues.
Linda and Karlene, thank you so much for sharing your time and insight. Thanks again for coming on the show.
Thank you, Kevin.
Thank you.